You are muted. Need to wait. Ask to unmute. Okay.
Okay. All right. Okay. And then I just want to be able to. All right. So, hello everyone. I'm just starting the slideshow to make these slides a little bit bigger. I'm so happy to be here today and giving this talk. So a little bit about my outpatient program. So I'm the associate director and at the McLean 3 East outpatient program. This has been a program that has been here for about 8 years, and it had exclusively focused on teenagers. And so first, what I'm going to do in my talk today is just orient a little bit to DBT, just because I do know that there are some people in the audience who may not really know anything about it. So just do a little bit of orientation to DBT, and then why have we now started working with DBT with adolescents? I mean, with pre-adolescents. So DBT is a treatment and we're going to go through what this treatment looks like with children. In its whole, it's a very comprehensive treatment. It has a lot of different parts to it. And the biggest piece that I want to emphasize is that we operate on different principles. And what we're doing is we're taking these principles and we are applying it to these different age groups. And what that allows us to do is to be able to be developmentally appropriate and to kind of shift the principles in ways that vary versus when you're applying DBT to adults versus when you're applying them to teenagers and now towards children. DBT is seen as the standard of care for borderline personality disorder, and also patients just who have multiple problems, who have been kind of chronic patients and are kind of characterized by having out of control emotions and out of control behaviors. And as I mentioned, DBT now has been used with teens and adults for many, many years. There's a lot of literature that support its use. In our program, as I was saying, we worked with teenagers and have been working with teenagers, and I've been working with teenagers for a very, very long time. And in our program, what we started noticing is some things that teens could tell us. And in part, this was them telling us at intake, but then also in part just through their course of treatment. And so one of the things that they let us know was that the suicidality that they were experiencing, the self-harm that they were displaying, for many of them, the overwhelming majority of them, those types of actions began when they were 8 or 9. When they were 8 or 9, it looked differently. The level of self-harm wasn't as extreme. They might be picking at their skin or making very small cuts, or using their fingernails to just, kind of clench their fists and inflict pain, things like that. And these teens were telling us, it was the same thing. I was doing the same thing. I was just doing it kind of in a less kind of out there way that nobody really noticed. And they talked about wanting to die. They let us know that their ideation was present. It looked differently, and that makes sense given their conception of death at an 8 or 9-year-old level. They had lots of problems with stealing. They had lots of problems with just interpersonal difficulties with their parents, with their siblings. And so a lot of their out of control kind of things were starting much younger. And many of them started saying, gee, I wish I had had this treatment when I was their age. The other thing that we know in our program is that most of these kids, most of these teenagers, had been in treatment for over 4 years, well over 4 years. Most, when I went back and looked at a lot of our most of our files, most had been in treatment since like the 1st or 2nd grade, which is in the United States around 8 or 9 years old. Most coming into our program carry 3 or more diagnoses. anxiety, depression, ADHD, oppositional defiant disorder, conduct disorder, autism, so many different diagnoses. The other thing they let us know was that most of their treatment did not involve parents at all. And if it did involve parents, it was bringing a parent into, you know, one session or another session, but not a consistent, no family therapy. It was more about maybe making a disclosure, that type of thing. And the other thing is that many of our teens told us they did not confide their kind of out of control behavior even to their therapists. Parents also let us know that they had at times sought treatment for themselves in terms of parent training, and that they found that that wasn't very helpful. And so dialectical behavior therapy, given it is a behavior therapy, some of our parents are kind of skeptical when they come into us and they hear, oh, behaviorism, we've done that didn't work. And so I'm going to talk a little bit about how our program is a bit different from kind of standard parent training, although we do incorporate parent training. Now, I want to highlight a disorder that's relatively new to the DSM. It was added in 2013, and it's called mood disruptive disorder. And this is all the criteria. I'm not going to go into all the criteria one by one. Basically, just to give you a sense that, you know, with the new augment of the DSM, there is some indication that people kind of understand that kids are having a hard time that some children are having a severe time managing their outbursts, managing their emotions. And you'll notice that in this criteria, most of them have to do with temper outbursts, not so much, so it's the outward aggression signs, not so much the inward difficulties that these children may be having. And I would say that now that we've started this program with children, many of our children 8 to 12 years old is our cohort of children do meet criteria for this disorder.
Armida, if I can just stop
Yeah.
Because you having the presenter's view and the slides are quite small.
Oh.
Yeah.
Okay. I'm sorry. Let me get out of here.
Try to have like a normal view.
Yeah.
If you go for slideshow and do just like normal view.
Okay.
Yeah, it's still like we have.
Yeah, it is, and I
It should be when you go for slideshow and then you choose for.
Yeah, for
Someone is saying press F5.
Okay. Let me press F5.
No, it's
no. Okay, I'm so sorry. Not sure what I have done. Okay, hold on a second. I'm going to stop the share for a minute and just go into it. Now it keeps taking me back there.
Okay, maybe we just need to accept that.
Is that any better?
Cannot see anything. And also, Do you have any headset maybe? Because your microphone is not so great. Okay.
We can get one thing fixed, for sure.
Okay, so is this better?
Yeah,
For
thanks.
volume?
Thanks.
Okay, and let me try this again. Okay. And okay. Let me. Is that any better?
I think this will have to just stay. This is the same one. Okay. Let's just keep it.
I'm so sorry. Okay. I promise that's the only slide that has really teeny font because that's the DSM slide. But I wanted to orient you all to the fact that there is a disorder now kind of recognized by the DSM in 2013 that kind of describes some of the children that we are seeing come into our program. Now, in terms of DBT and how DBT understands these issues, is that DBT kind of takes the idea that this is a dysfunction of the emotion regulation system. In other words, the out of control behaviors that we're seeing, suicidality, self-harm, aggression, things that look like hyperactivity, those types of things, that those are coming out of the fact that the child doesn't know how to manage these emotions that the child is having. And so in order to try to manage those problems, that problem of having all of this emotion and I don't know what to do with it, that they engage in some of these behaviors. So in BPD, and I know Alan mentioned that this morning, is really kind of a prototype for emotion dysregulation disorders. And DBT is really the treatment of choice for emotion dysregulation disorders. That's one way to think about this piece. Now, in terms of the emotion dysregulation disorders, as I was saying, these disorders, they function to help regulate these behaviors. Now, the examples that we're seeing in the kids that come into our program are things like aggression, suicidal thinking, even suicidal attempts, verbal outbursts, other impulsive behaviors, things that look like hyperactivity, where they can't sit still, yet they have not been necessarily diagnosed with ADHD, although many of our kids have been diagnosed with ADHD. And it's kind of like, and I realize you all are seeing this on a really small screen, so I'm very sorry about that, but there's a little person who's saying, I try to be good, I do, my heart is as pure as driven snow. It's just that, well, sometimes events beyond my control conspire against me, right? It's not that these kids, they're doing the best they can, and they seem to not be able to manage their emotions, which then creates a situation where they engage in behaviors and suddenly they feel out of control and they look very much out of control. Now, in terms of the biosocial theory for emotion dysregulation disorders and with children, what we do is we present, and we do present these theories to our kids, to 8-year-olds, and we talk to them about how we view them as being exquisitely sensitive kids, and that they then transact with an invalidating environment. And I'm going to go through and talk about each of these, and that results in emotion dysregulation. Now, their sensitivity, this is a transactional environment. So when they're really sensitive, about something and the environment responds in, you shouldn't feel that way, it's not that big of a deal, that then results in the dysregulation. Other times they're being, you know, normatively sensitive, and the environment is still somewhat punishing of them, and it results in emotion dysregulation. So it's a transaction, right? Sometimes the kids will be sensitive about something, not be able to express what they're feeling, what is happening inside them, not be able to express it in a very accurate way. And then the environment reacts to their words, but since their words were inaccurate, it ends up being an invalidating response and even more dysregulation, right? So it's not, this is not a blaming model. This is a model that's kind of acknowledging that there's a transaction between this child and the environment that leads to emotion dysregulation. And what this does is it sets it up so that we can actually intervene at the child level, at the environment, and at the environment level. And I'll talk a little bit about how we do that. So in terms of what does it mean to be exquisitely sensitive? So the children that we see, we'll talk about, we talk about high sensitivity, high reactivity, and a slow return to baseline. In the children that we see, we basically see children who are easily upset more than what other people would be in general. They seem to kind of have that ability to pick up on other people's emotions incredibly well, even at a very young age. They tend to have high reactivity, meaning their emotions are intense, and they tend to have very strong reactions. So it's not only that they kind of feel emotions easily, but they react in a very intense way. They might become incredibly aggressive, and they have a hard time coming back down to kind of a baseline, hard time remaining calm. And when we go through the model a little bit more explicitly, I'll give you an example of the types of things that we see with these kids. Now, an invalidating environment is, and we talk about invalidation not just in family environments, but also social environments. These are school-age children, and sometimes the schools become an invalidating environment for these kids. Now, these environments, as I point out here, they're not necessarily mean or abusive. That's the extreme form of invalidation. And they're not even necessarily neglectful, and they're not uncaring. Many of our families are incredibly caring. They love their children. You can sense the love they have for their children. The schools are seriously doing the best that they can. They have very caring personnel. So of course, abuse at either home or at schools, of course, that would be invalidating. Our point here, though, is that it's not just that, right? What it means is that invalidation is when somebody's behaviors, their wants, their emotions, their kind of private behaviors, right? Because like, how do you know what a child is feeling? You can read their expression. You can kind of ask them, right? But we don't really know what's happening inside of them. And sometimes those behaviors, if they're not able to communicate it accurately, or if you as an individual have a really different response to a situation, right? We are not going to communicate that whatever they are doing, whatever they are feeling, whatever they are wanting is valid. We might downplay it. We might, basically say, oh, that's not such a big deal, right? They're 6 years old and they've had a fight with a friend. And as an adult, you might think, really? Okay, right? And that in and of itself, of course, does not create harm. but a repeated history of that may have children unable, leaves a child unable to know, what do I do with my emotion? Because it is that big. The fact is that the child is that having that big of an emotion to a fracture in their peer relationship. So they might be misunderstood. They might be criticized. And sometimes what happens, and one of the patterns that we see with our children, is that when they become suicidal, when they become more self-harming, that those are the behaviors that then get paid attention to. In other words, those invalid behaviors sort of become the legitimate thing. Those are the ones that get reinforced. Now, many times when parents see their child engaging in out of control behaviors, the attempt is, let me try to control it, especially when you're talking about little people, right? When they're 8, 9 years old, where parents still have a great deal of control over a child. And so parents want to control it because they are trying to keep their child safe. They are trying to make their child feel better. However, what often ends up happening, and what we see in families, is that this then turns into aversive control. And we see much more punishment being administered by families to try to control a behavior. So for example, a parent who wants their child to wear a bicycle helmet when they're riding their bicycle, and they have learned that their child is putting the helmet on when they're home, then the child takes the bike, goes around the corner, takes off the helmet, leaves the helmet in the bush, and then rides around, then comes back, puts on the helmet, and comes home. And a parent is often tempted to say, well, that's it. If you can't wear your helmet, then you can't ride the bicycle, right? And that's an attempt to control that behavior. And so we're going to talk about how what we do to try to control that behavior, acknowledging that a child, once they are out of your view, you don't have as much control over them as maybe as a parent you'd like to think you do. We focus on how an invalidating or a social environment might punish actually when a child is being accurate. So for example, a child in school, sometimes this happens in school, where a child who's very, very sensitive may have difficulty with the way their lunchtime had gone with their peers. And they are feeling very sad about it. And a teacher says, you know, oh, come on, they didn't mean much by it. Just get back to class and don't think about it anymore, right? Well, now you have the situation where the child has reached out for help, but that has been discounted as a real need for help. And they are left without any help and are also told, you really shouldn't feel that way. And of course, this is a well-meaning adult who's saying, you know, it's not that big of a deal. Don't think about it. Go back to class, right? There is nothing, you know, nefarious in that. It is that the adult is trying to just get the child to redirect and go back to class. With a very sensitive child, that leaves that child without any assistance in that moment. And so what may happen is that then the child, without any help, starts escalating, right? Okay, so, you know, you didn't take, this is not a conscious thing, but they go back to class, they keep thinking about what happened at lunch, what happened at lunch, what happened at lunch. Their teacher wants them to engage in some material. They're still thinking, what happened at lunch, what happened at lunch, what happened at lunch? And then, you know, the teacher asks them a question and they say, ah! You know, I don't know, you know, and then the teacher's like, go to the office, right? Now the kid gets to go to the office, and now everybody in the office, what happened? What's wrong? You know, Johnny, you usually don't act that way. What happened? Mom, what's wrong? Right? Suddenly they've escalated, and now they're getting the help that they really kind of needed the first time around. Sometimes, as I pointed out, sometimes we minimize the difficulty that 8 and 9-year-olds have. We're adults. It's actually very easy to minimize the difficulties of what they're going through. And it's easy to kind of oversimplify how easy it is to solve the problem. The problem with that is that they don't know. Developmentally, there's no reason they, quote unquote, should know. And it leaves them without any skill set to actually solve those problems. Now, the thing is, invalidation is much more likely when, as I've mentioned before, when it communicates a private experience, an emotion, a desire, right? Those behaviors, there's no way for us on the outside as adults guiding these children to know exactly what they're going through. It's also more likely when the behavior is self-generated. In other words, it's coming from themselves. Now, this starts becoming a thing when they are about 8 or 9 years old. They have much more agency. They can make choices that don't necessarily, that are from themselves, not just under control of what's happening in the immediate environment, right? When they're 2 and 3 years old, right, kids don't have many choices. The parents are in control of the choices. As the child ages, the child becomes much more in control of those choices. Sometimes invalidation is more likely when a behavior puts demands on others above the level they prefer. In other words, you know, so for right now in the United States, many of our kids have, quote unquote, gone back to school. However, back to school means doing school at home for many of our, a lot of our population right now. This is placing serious demands on parents in ways that, you know, in ways that they really don't want, and in ways that parents don't necessarily have the skills to help manage. So it makes invalidation more likely. Sometimes we don't have the ability to meet whatever the need is that the person has. Many of our parents say, I just don't know what to do when they start screaming, and or when they say, you know, when an 8-year-old says, I want to die, I don't know what to do. Of course, you know, and there's no reason why parents should know what to do. And that just makes it more likely that an invalidating response may occur, even when parents are trying their very best, or even when adults in the school system are trying their very best. Another thing that can happen is that sometimes you have a kid who's very sensitive, exquisitely sensitive, and you have a parent who just isn't. That is not the world in which they live. And they have a very hard time understanding, why is everything so emotional for you? I am not that kind of person, and they just can't understand what that situation is. Okay, so in terms of the way we try to look at our treatment with kids is that we have kids who are exquisitely sensitive, right? This upper box here. We have kids that are exquisitely sensitive, and something happens. So I'm going to tell you the story of a 9-year-old who was in our program. And this 9-year-old has a mother who has a lot of medical problems and has had various surgeries. And the child is very sensitive to to emotions, tends to be very reactive when he feels a lot of emotions. He can become either very aggressive or incredibly sullen. And it takes him a long time to be able to kind of come back and kind of function normatively in the world. The event that occurred was that his mom had a surgery, and the surgery was not life-threatening, and he began to kind of think that, he started having judgments because after the surgery, she needed to come home and rest in bed. And she needed to just rest. And he began having these judgments that, it's been 2 days since your surgery. You really should be able to get out of bed now. Like, that's enough. Like, you should be able to get out of bed now. And what happened was his emotions around that event of her having surgery kept going up and up and up. And he started saying to her, the inaccurate expression was, he started saying, you should get out of bed. He wasn't talking about his distress over his worries about her, which we ended up talking about at some point. But his expression to her was, you should just get out of bed. Her response was, I'm tired. I need to stay in bed. That led to him getting even more aroused. He came into the room with some pots and pans and started banging on them, saying, get out of bed, get out of bed, get out of bed, right? The inaccurate expression, right? She, at that point, well, actually her husband came in at that point and escorted him out of the room. He then went into his room and began destroying his room, throwing things, breaking things, everything else, right? The father said, that's it. You are now banned from any electronics for behaving that way, right? Now, that situation, right, is this model for emotion dysregulation, where the child is incredibly sensitive and starts having high emotional arousal, can't really express what that emotional arousal really is, starts then engaging in an accurate expression. Parents are responding to his expression, right, of banging the pots, of, saying get out of bed. The issue is that invalidates his emotion response. Now, there's no way for the parents to know, right? Remember the slide about what makes it more likely for things to be invalidated? Well, when you don't know what's happening, right? When you don't know what's happening within the child. Then this ultimately resulted in him becoming totally dysregulated and, kind of destroying his room, right? Which was met with further invalidation from the dad, because the dad made it about the room, not about his emotion regulation. Now, parent training programs, I do want to mention about parent training programs, because parent training programs are relevant here. And as I mentioned previously, many of our parents and children coming into our program, they've tried parent training programs, and many solid parent training programs really teach solid use of praise, solid use of positive reinforcement, how to implement consequences consistently. And many families benefit from this, and kids learn how to modulate their behavior, to meet the expectations, to get the reinforcement. And I've listed some of the kind of most heavily researched parent programs here. The problem is that this is a transactional model. So in a transactional model, remember, so it's not only that the child is having heightened emotional arousal. When the kid came in banging the pots, what do you think was happening to the mom? Right? The mom's emotional arousal was going up, right? The husband who's trying to take care of his wife, right, and is seeing like, okay, my wife is not getting the rest she needs, my kid's being out of control, right? The husband's emotional arousal is also going up, right? In that transaction. So it's not only about the kid's emotional arousal, it's also about the parent's emotional arousal. Because as an adult, we respond quite differently when our emotional arousal is not so high than when it is very high. So as this cartoon is saying, you know, you've got this father saying, you broke the binoculars. Didn't I tell you to be extra, extra careful with them? Isn't that exactly what I said? Well, those binoculars were brand new. Have you no respect for other people's property? And the little boy says, I have an idea, Dad. Let's pretend I already feel terrible about it and that you don't need to rub it in anymore. Right? And this is the situation that we find that many of our families are struggling with. So just a brief overview of what DBT looks like. So DBT focuses on enhancing people's capabilities. So this is kind of general DBT, and then I'm going to talk about DBT with kids. Enhancing people's capabilities, in other words, skills training, working with individual therapy, group therapy, or family therapy, having phone consultation, having a consultation team where the therapist is meeting to receive team consultation, and then working with the environment. So that's kind of standard DBT. In terms of what our treatment looks like with these children and what are we trying to change, how are we trying to change that transactional model where you've got a lot of heightened emotional arousal leading to inaccurate expression, then leading to invalidation. How are we going to try to change that? So with DBT with kids, what we really focus on is helping kids to recognize and really understand their emotions. Many of our kids come in and they often, their response to questions about emotions is often either I don't know or I guess, or they don't really have a firm language. So that's one of the things we're going to help them develop is a firm language of their emotion. And how do you know what you're feeling anyway? How to better manage their own behavior. So instead of going and breaking up your room, what else are you going to do? How to cope with problems. Life is filled with problems, and we want to help our kids learn how to cope with those and not make them worse, and how to problem solve those difficulties. The DBT therapy that we administer also focuses heavily on parents. And this is one of the things that is different from our teen program. Even though in our teen program, we have family therapy, we do work with parents, they are integrally involved. In DBT with kids, given that parents still have so much more control, and parents and children are much more open for the parents to be able to do the in vivo skills coach training and skills coach acknowledgement with their children at home. One of the things that we focus on is we really want them to understand what is it that their child is kind of trying to do when they're banging the pots, and what's the function of that, and how to respond to that in an effective way. Effective meaning being for the child to be able to then learn, like, okay, let me learn how to express, Mom, I'm really scared. I'm really worried about your surgery, and you're making me really scared because you're still in bed and it's 2 days, right? Maybe the child needs some, in that case, needs to understand, like, oh, it's going to be 5 days before Mom's going to have a regular schedule, or, whatever the case may be, but being able to express that. We want the parents to learn ways to manage their own emotions that get in the way of them effectively parenting. I know that Alan mentioned some of the studies that they've been doing with regard to parents and acute stress disorder and PTSD symptoms. And it's not only that, many of our parents, even with these young ones, are coming in with those types of symptoms, the acute stress disorder symptoms. And so we want them to really learn how to manage their own emotions that interfere with their ability to implement effective parenting strategies. And that's one of the things that we've noticed in terms of, we involve many parenting training program strategies within our system the issue is that sometimes parents need help implementing what skills am I going to use to manage my own emotion so I can implement this behavior plan effectively. So we do talk with them about how to learn ways to effectively set limits, but this is after them gaining some skills in how to manage their own emotions. Because when their emotions are really high and they're feeling at the edge of the cliff and wanting to kind of like metaphorically jump off, there's no way for them to be able to implement a behavior therapy plan. It is not going to work. And we kind of acknowledge that. We do teach the effective limit setting. We teach them how can they understand their child's emotion? If they really are seeing their child as an enigma, like I don't understand the world in which my child lives emotionally, we want to help them. How do they understand that? Because if they understand that, then they'll be able to validate it. And so they can practice their validation strategies. And then, of course, how to help their child effectively problem solve difficulties. But that's after kind of focusing on the validation and working on the emotional part with their child. We do have, so what does our treatment look like? It is a comprehensive treatment, and there are a lot of sections to it. I joined Alan's talk at the very end, and I know there was some discussion about kind of limited resources. And one of the things that I want to acknowledge is that many of our families have expended a lot of resources before coming to our program. They've had individual therapists. They have had home health people. They have had school counselors. They have had parent training for years. And so our program, while you'll see it has many different treatment components, and it is intensive, and I can talk more nitty gritty about how do we do this, because we do work, we have a fairly small team, but we get this to all work together. So one of the things that we start off with is a multifamily skills group. This is a skills group only for parents. In our teen version, we actually include the teen and the parents together in our skills group. This one, it's only parents. And the goal really is to develop their skills as parents so that they can help their child with skills. So this is akin to, they need to put their, in an airplane, you need to put your mask on first. If the mask drops down, you need to put your mask on first before you help your child. This is the same kind of idea. We want to help them develop their own skills. We do focus a lot on acceptance and change strategies, focusing on emotion regulation and other DBT skills for the parents to use for themselves first, and then teach validation and behaviorism techniques that are based in a lot of the well-developed standardized treatment for parent training. We implement family therapy, and in our program, the family therapist and the individual therapist is the same person. We focus on really how to create a validating environment that promotes accurate expression with the child. We do a lot of talk in families about learning about emotions. We help parents and kids see the kind of chain. So with that child that I gave an example of previously, we went through that situation to be able to highlight, like, okay, so your emotions went up and then you engaged in an inaccurate expression. Let's talk about what emotions you were having there, right? So that the parent could understand this was really about the child's worry and concern that mom may not be getting better and maybe mom's life was at risk. And then how then that changed the parent's reaction to understanding what the banging the pots was about and helping kids learn how to problem solve. We do have individual therapy with the kids. We do teach them DBT skills. The DBT skills are modified from traditional DBT. I'm not going to go into all the different ways we've modified these, but we've made fairly significant modifications just to be able to make them more developmentally appropriate towards this age group. And we practice a lot in session. We do a lot of role playing in session. We also then assign a lot of role playing at home. with these parents and kids. We also assign role playing at school. So yes, we do talk to the schools. Most of the schools in the US, the schools have counselors. We orient the counselor to what are the skills that the child is using to be able to help generalize that to school. And then we do have skills coaching where we are available as a skills coach to encourage that generalization of the skills outside of our program. Because our goal is this, right? The kid is going to still be an exquisitely sensitive child. The difference is they are going to have learned how do they manage that emotional arousal. Because when they manage that emotional arousal, they can then express themselves accurately, which makes it much more likely for them to receive a validating response. And if they receive a validating response and that becomes consistent, it actually makes it much easier for them to manage their arousal. Okay, and thank you very much. And I think we have time for questions. I am so sorry that the slides were small. And Magda, if it would help, I'm happy to send these along so that people could maybe see a larger version of them.
Okay, that will be great, definitely. And by the way, Przemysław, who is taking care of the technical thing, he discovered why your slides are so small. So I can tell you later where to click.
Okay. Okay.
This is on you. And we have some questions. We have some comments and questions. One is referring borderline symptoms in children and Asperger's syndrome. What if this is misdiagnosed one or another way, or if it's possible for children that they have dual diagnosis, Asperger and borderline? So how you differentiate these two? Because the problem of emotion regulation is present there.
Right, right. So, you know, within our program, as I was mentioning, many of our children come in with a wide variety of diagnoses. So our 8 and 9-year-olds are coming in with, you know, 3 or more diagnoses. And certainly sometimes Asperger's is part of that. Borderline, not so much, because at 8 or 9, and really within our program, right, what we look for, we do implement, you know, some standardized protocols to do diagnostic assessment within our program. And what we are really looking for within our program is to determine, is some of the behaviors that are being seen, do they seem to function to help manage emotion? And if the answer is yes, then typically we will kind of say, okay, this looks like someone who could benefit from DBT. So yes, for insurance purposes, so my program is an insurance-based program. I need to be very concerned with diagnoses, and we do that piece. And so that's kind of like, we do that piece because we have to do that piece in order to be paid, which is important. And really for working in this area with these small kids, because this is, I mean, this is our 2nd year of this program that we're working with the kids, is that what we're really working on is, because DBT really is based on those principles of a treatment for emotion dysregulation, is looking to see, are the behaviors that we're seeing really serving to function to regulate emotion? And if that's the case, then really having them come into our program. So I'm not trying to skirt that question. I'm just saying that in terms of as it relates to our program, how we kind of take a look at that.
Okay, thank you. One more question is if the program will benefit children who have so-called difficult temperament, like biological temperamental issues, or the children only whose problems they come as a result of environmental factors. So if we go for change of more skillful, more validating environment, the children with biological factors will also benefit from that.
Right. So, so in terms of looking at, you know, the kids who are, that we see that we've deemed kind of exquisitely sensitive, the idea is that many of those factors may have a biological basis. And so that's why, like in that last slide, I said, you know, our kids are still going to be exquisitely sensitive. The difference is going to be that they're going to learn how to manage some of their own sensitivities, some of their own reactivities, how not to make it worse. And the environments, right, their parents in particular, because they're young children, become much more validating. And so kind of being able to intervene at both levels, right? Not only because these are, remember, these are kids who in the past we probably would have seen when they hit teenage years. And what our teens kept telling us is that the past, in the past, when they only had treatment as kind of child only, that really wasn't sufficient for them. That working with the child and the family together seems to be a much more fruitful kind of in terms of change, what we're seeing. Given our program is only a couple years old, we are starting to follow, and we do have some research that will come out later about our program. And right now, just in terms of following our kids that have graduated our program so far, you know, what we're seeing is that, you know, the schools are reporting less difficulties at school with either engagement or you know, conduct issues, those types of things, and the parents and kids are engaging in quite a different way.
One more is when we apply BPD criteria, diagnostic criteria for children, it's not gonna serve the purpose really.
Right. I mean, I think there's, so, you know, I think in terms of, and I think this is such a complicated question. So I think part of it is, right, DBT is really associated with borderline personality disorder. That is a disorder that it is totally associated with. And it is now being seen, and you know, we're really trying to promote it as a treatment that has a much broader focus. The likelihood of us being able to deem, you know, children 8 and 9 years old as having borderline personality disorder, I don't think people are going to do that. And I'm not sure that's appropriate either. We run into the issue, though, of how do we help families find DBT with children that does seem to be helpful in terms of preventing the escalation of some of these more significant problems. And that, you know, even our 8 and 9 year olds now, and the parents in particular, are saying, is there any way we can just like have this for parents from the very beginning, so that parents can learn about how to help like little kids, like 2 years old, with emotions, how to create a more validating environment. And so I think part of the issue of the borderline diagnosis, that leads to kind of more, you know, people hear borderline, they start thinking DBT. So I think it does become a conundrum of like, how do we ensure that parents and families, that parents and kids and schools know that there's this option that is becoming more widely known as DBT for these younger kids, you know, starting at 8 or 9 years old.
Okay. One question we have is, what about children who have developmental issue and autism spectrum or mental intellectual disabilities?
Right. Right. No, and that's going to be seriously important for us to kind of look into. Right now, I can tell you that the people doing work with children of this age, have not ventured into that area. And that is an area that I think we are going to learn, we are going to have to figure out how do we do that. There is some work, what will be helpful in that is that there is some work with an older population of using DBT with people with developmental disabilities or with autism spectrum. And so, you know, I think that some of that work can be used to figure out, like, okay, how do we do that with a younger population? And certainly that's important work that's going to need to be done.
Yeah, so I'm seeing that was about exclusion criteria from the program. What would be the exclusion criteria?
So,
because I think I know from also my experience and my colleagues that parents who are very determined, parents who are very determined and they observe emotional issues with the children, being like high emotions, they will look whatever help they can get. So would you say there are some exclusion criteria?
So within our program, given that, you know, so our program, I think part of our program, what helps is our inclusion criteria. So our inclusion criteria with kids who are at this age range in our DBT program are children who have experienced suicidality and or self-harm. And so that's one of the biggest inclusion criteria. So if a child is, you know, maybe having like, you know, depression, anxiety, has been diagnosed with conduct disorder or something that, you know, indicates kind of aggression, that those aren't the children that we're actually currently taking within our program. Because they don't have one of the hallmarks in terms of safety. So that's one of the things that we do. You know, so within our program, right now, really the only kind of exclusion criteria that we have right now is actually people, kids with developmental disabilities, just because none of us feel like we have that expertise in that area to work with that population. And again, like the children coming in either have suicidality or self-harm, plus all of the other kind of impulsive, aggressive, other out of control kind of behaviors. And so that really kind of, quote unquote, narrows the field. We do get many calls from parents who are kind of at their wits' end of, you know, what do I do with my child who aren't suicidal, who aren't self-harming? And then we refer them to just start our child outpatient program, and which is connected within McLean. And if through that we become aware of a child actually having more difficulties, because as I mentioned, sometimes children aren't disclosing to their therapist initially about self-harm, that provides an avenue for them to come into our program.
Okay. Yeah, I think these are the most important issues that the people have lots of concern about. Diagnostic, if this is conduct disorder, these are early personality disorder like signs, or this is what makes confusion actually for early intervention. This is quite, yeah.
Yeah, and I think that's in part, as I mentioned, you know, our kids, the 8 and 9-year-olds, are coming in with, you know, a lot of different diagnoses. And so what we're really looking for in terms of our DBT program, which was set up to really treat this kind of pervasive dysregulation, plus parents who don't know how to manage that, right, and creates an invalidating environment, and schools. We end, excuse me, we're not as, we look for those factors and that function of those behaviors, because what that can lead to, if you look at the diagnoses in our program, there is a wide variety of diagnoses in our program. Because the kids do, when we kind of like check off, what are they meeting criteria for? They're meeting criteria for some of these other things. It's just within our program, right? The principle is these are problems of emotion dysregulation. And do we have the tools to help manage that? And these are problems of an invalidating environment. And do we have tools to manage that? And so I agree, the diagnostic thing can get you kind of like, but which is it, which is it, which is it? And this is why kind of within our program, we're focused on, okay, what do we actually treat? What are we actually focusing on?
So you go for understanding the problem, the function, and the solution. If the solution that child is using to deal with the emotional problem is the problem itself, you know, like this way, it's one way. Or if the environmental factors, yeah, are also matching the available interventions that you are, yeah, that you are offering. Okay, okay. I think this is important for all of us to hear in this way. Okay. We are just right on time.
Yeah,
Thank you
very much.
Thank you very much, Armida. It was great to have you. And from the comments, I see that it was really great inspiration for many, many people. And yeah, thank you.
Yeah,
thank you.
No, wonderful. Wonderful to be here. Thank you very much.
Okay. Okay, thank you.
Bye.
Bye. Teraz zrobimy sobie 5 minut przerwy.
Now we are going to have a 5-minute break. Let's say 5-7 minutes break. And we'll move from the United States to Italy. And shortly we will have our next guest with us.